Okay, great. I see that Andrew has joined, and so I'll introduce us and give a really quick overview, and then I'm going to have Andrew give details. So I'm Jennifer Boyd. I'm a physician assistant and a prescriber in our MAT program at New River Health Association in Oak Hill, West Virginia. And Andrew is my partner. It looks like he's figuring things out there. And Andrew is a behavioral health counselor. And so we work together with our weekly group, people who have fewer than 90 days of sobriety. So Andrew, are you able to unmute there? I hope he can figure it out.
Yeah. Can you hear us, Andrew?
Yeah, there he is.
There you go.
Beautiful.
Wait,
oh,
no.
Can't hear
Okay.
you. Oh, you unmuted, but we can't hear you.
You'll have to go into your audio settings, most likely. You see that like little carrot shape next to the mute button on the bottom left of your screen. Even when you just click that, you can select the speaker and the microphone, and you just want to make sure that it's connected to the correct speaker and microphone options. It's like a little check mark on the top part of that carrot menu.
Like you're looking in the right place, Andrew.
Looking down in that.
Yeah. So I could, Andrew, as you're figuring that out, I could start to talk about our case.
No worries. Yeah, I apologize.
Yeah, I don't.
That can be troublesome.
Oh, there we go. Connecting to audio.
Good sign.
Yeah.
And then you can always chat Mitra too. She is the secondary over there, and she can help out during this process.
Yeah. So if you want to, I know Andrew's really excited about presenting, so I don't want to, we'll see, but
take it away.
Andrew, it looks like you're getting there, so I think I'll just start. So we wanted to get some feedback from the group on, oh, there you are, Andrew. Can you speak now? Well, anyway, from the group on our patient, who is a 45-year-old white female. She has Medicaid insurance. The things that we're interested in getting feedback from the group on is we feel like really basically what we're doing is harm reduction with this patient. She is super complicated. And I'm not sure what SMI means. Andrew completed the case form, so but he put, what are your experiences with SMI patients, best practices? So
I think it's serious mental illness, Jennifer.
Okay. Okay, thank you. Yeah, and that is really the big issue with this lady that we're presenting. So so this is a 45-year-old lady. She was born in Colorado and moved as a child to Oak Hill, West Virginia, which is where we live. You can see from the case presentation that her dad was a helicopter pilot in Vietnam, and that she said he was mean. He currently lives in Pennsylvania. Her mom lives in Tampa, Florida. She has more contact with her mom, who has told Andrew that she basically contacts her mom when she needs something. And the mom, I think at this point, has stopped kind of bailing her out on things. The parents were divorced when she was 6. She was abused by her stepdad sexually when she was 13. She went through the ninth grade and got a GED. She was married for 13 years in what she describes as an abusive relationship. She has 1 daughter, she has 2 grandchildren, and she has contact with them. She babysits for them every so often. She applied for SSI in 2019 and was denied, likely because of a history of heroin addiction with hospital hospitalization. She appealed in 2022 and it's still being reviewed. She is currently living in the extra bedroom of an ex-boyfriend who she says has threatened to evict her, although he hasn't followed through on that threat. She says that he withholds food from her, and she says that she's only eating the minimum amount of food to survive. She has lost a tremendous amount of weight in about the past 8 months, from 140 to 103. She doesn't have any source of income, so she relies on this boyfriend and from other people. Her drug of choice is heroin or fentanyl, which she continues to use. She also tests positive weekly for methamphetamine, and she denies using it. So who knows? But it's in her urine regularly. She uses once or twice a week. She entered our program a year ago. She comes every week to our program. She, for the most part, also attends our required 4 NA or AA meetings per week, mostly through the ones that we offer. So she's very connected to our team and to our group. We have 3 or 4 other people in our weekly group who continue to use weekly and have been in that group for between 1 and 4 years. And so she's sort of bonded with them. She's really knowledgeable about mechanics. She was giving advice. I laugh because I'm not, and I'm sort of sexist about it. I'm always amazed when a female knows about cars. She was giving advice to one of the guys one day who was having car trouble. I was just thrilled to hear her do that. But anyway, and also is knowledgeable about the Bible. Some of the difficulties that we face with her, aside from her continued use, are that she, first of all, I don't think I guess we listed it in comorbidities. She has, you could stay right there, Elizabeth, thank you. She has anxiety and depression and probably other psychiatric diagnoses that I'm not really can't speak to, but she does talk about auditory hallucinations to Andrew. I know that, and visual. She's in the care of our psychiatrist. We should have listed her medication somewhere, but we'll come to that. And she comes in pretty often saying that her medications were adjusted and she thinks it's helping. She has chronic back and neck pain from a car wreck. And she has really severe dental issues. She had all of her teeth extracted this spring and is still struggling with getting dentures that fit and don't cause irritation in her mouth. She's currently enrolled in our dental program. She had been seeing an outside dentist, and that was a whole nother terrible story that I won't get into here. I'll go back up to deficits. As I mentioned earlier, her mom and her daughter have backed off from giving her support. She's hidden heroin in her house for years, according to the mother, and every so often she'll come in and say, oh, I found some and I used. She is scheduled for individual therapy monthly. Andrew's note here says she's not engaged except for during crisis periods. And following up on her SSI submission. She does not offer a lot during group. She has good eye contact with me, but she often will just say, I'm fine, or I had a terrible week, but I'm going to do better. She doesn't really disclose a whole lot in group, even though she is bonded with several members of the group. Let's see, you can see a few notes about her medical history, back and neck pain, hysterectomy 2014, Hep B positive. So I am sorry to say that I was not aware of these aspects of her history. That sometimes happens. And so that So back to our question. She's a really super complicated patient. We think a lot of it has to do, well, obviously there's history of trauma. There are the, complicated psychiatric history. I'm sorry, I don't have the medications listed. I could look it up. I thought I put them on the form, but I could look that up. And her continued use. I'm more let's say anxious about her continued use because it is fentanyl or heroin than I am about a lot of people. I mean, a lot of people who are in our weekly group who can't seem to move on are using meth, and she's using meth, whether she admits it or not, or whether it's cut into her other supply, but she freely admits that she's using fentanyl or heroin. And so that just makes me more nervous about her overall and her risk. So our approach has been harm reduction with her, just keeping her engaged in care. And yeah, that's about it. We wanted to see if anybody has any thoughts. Andrew, are you able to hear and speak? No. Oh, so sad.
You can also
Andrew's
type
pretty
in the chat too, Andrew. We're okay with that completely. We understand the tech issues.
Yeah.
Apologize. I hate
Jen,
that.
before anybody gives feedback, could I just ask a few clarifying questions that I didn't see?
Most definitely.
Okay, thanks. How long has she been in your weekly group?
For a year.
Okay. And has she ever been, or is she receptive to going to a higher level of care like detox or residential?
She's not, and she's not, and what she says is that she couldn't leave her her grandchildren, that she just has a responsibility for caring for her grandchildren at times, and that so that's what she states. Laura asked if she's testing positive for buprenorphine, and she is. One other element before I forget, Tony, is that, and this goes back actually to an earlier conversation we had about PRSS. Our PRSS has seen her, has disclosed to me that he has seen her out and about with a known meth dealer in the community. And so I think that even though she says she's not using this, I think she probably is maybe buying it. And that's the other thing is, this issue of her losing weight and not eating. We've bought her Ensure, we've given her Ensure coupons. People in the group have bought her food. And so anyway, it's one of those unfortunate situations where she's clearly getting money to buy drugs and not to buy food. And some of that may be related to the situation with the boyfriend, but I can't get a good feel for if she's completely truthful on that.
Hey, Jen, this is Andrew. I finally got my audio fixed, and thank you very much. But
I'll shut up.
No, I'll pipe in because I don't know what you've said. But I'll just listen and comment as needed. Thank you very much.
Great. I went through the case form that we prepared together, and then Tony DiCiacchio is asking, and Laura Simmons had asked a couple of clarifying questions. So that's where we are.
Okay.
And then one more clarifying question. What when she first started with you a year ago or whenever, or even now as she's getting ongoing treatment, does she share her motivation, like why she's with you, why she's seeking treatment right now?
That's a great question. I'll field to Andrew. Has she talked to you about that, Andrew?
Well, she shares that she wants Suboxone and that the drugs help mitigate the voices.
Do we know what other diagnoses she has?
Andrew, you had listed anxiety and depression, but this thing about the voices, I mean, do you know what the diagnoses that account for that are?
you know, it is, one would be a PTSD type diagnosis with a psychosis involved. That's a good question.
Has she been using methamphetamine for a long time?
It seems like more heroin for the past maybe year and a half, not necessarily meth.
Okay, I only asked that because chronic meth users, we see a lot of psychosis in them that were not present before chronic meth use.
Yeah, that's a good point. Andrew, did you know her before she came into our program?
Oh, yes. I knew her probably in 2019. And she at the time was working at Walmart, probably 15 hours a week. And she had to leave Walmart, number one, because of chronic pain, and number two, of the anxiety attacks that she was getting. I don't believe she was using any drugs at the time. So when she finally left, she pretty much went to her bedroom and was at the other people had to come and help her, like her daughter, neighbors. So she's relied on other people for food, for everything. So she spent at least a winter. Someone fortunately brought her some fuel, some wood, to heat her house. And this was back in 2019. Her main goal was to get on SSI, which was a good goal at the time. Apparently, she couldn't go to work. When she was working at Walmart, others would cover for her and try to help her out, which is kind of this pattern of her being continuously rescued by others. Her mother had rescued her, and her daughter also, and also a boyfriend at the time. And to my knowledge, there wasn't any drug use. She's pretty straightforward about that. And then probably a year and a half ago, she ended up, or a little bit longer, she ended up in the hospital, the local psych unit, and the drug use came out. She was using heroin.
Do you know much about her educational background? Is she someone who was in regular classes, special classes, or advanced classes?
Oh, you know what, I don't know right offhand.
No, either. But one interesting thing about her work history is that she's held a managerial position. Isn't that right, Andrew?
Right, yeah, for 8 years, the manager at the local Holiday Inn, the night manager. So it was a managerial position.
Thank you. Do we have any other questions before we go into our post recommendations going ahead with this patient?
This is Andrew again. If I don't know what Jennifer had said, but certainly I think she benefits from this program. It gets her out of the house. Before, she was just locked in her bedroom, basically, and only coming out to eat if there was food in the refrigerator. So she is getting out. She's attending meetings, continuing to use, continuing to lose weight. But the meetings and the socialization are of some value.
If it's getting her out, getting her attending things, building structure, that's always positive. Probably having the Suboxone in her system is probably what's really keeping her going with the continued use. If there's definitely fentanyl showing up in the system, I mean, she could still have an overdose, but it's going to prevent it from being too bad. So it definitely fits in line with a harm reduction model. And you're talking about people are always saving her. And it kind of makes sense, especially with the avoidance there. I mean, she's had a long chronic history of abuse and neglect. There's probably some learned helplessness going on there. And it might be like she's fully capable of getting a managerial position, doing really well, but then when times get tough and it's too much, she might revert back to, well, I can't do anything about this. I just want to numb everything and make it go away. So continuing to encourage her these things, even if she's still using, if she's going to meetings, participating, just encouraging her to empower herself could eventually build her back up to something else. I don't know where I started with that, but I rambled.
This is Andrew again, and I'll just pipe in. And I had thought perhaps a change in counselor would be good at this point, truly. That because I'm at a standstill. I'm at a block with her counseling wise. That probably would be a good idea.
Thank you.
And Andrew,
Go
that's
ahead.
that's group therapy that you're talking about, or is that individual?
Well, I'm the group leader in the group that she's in. She's in the group that is 0 to 90 days clean. And of course, every week she tests positive for numerous things. So, and I'm the leader for that group. Did we go into group participation?
Yeah, I did, but
Yeah.
Andrew also is referring to, he's also her individual counselor, and I think that's what he's speaking to
Okay.
with considering
Yeah.
changing. Yeah.
Uh-huh.
Mhm.
Yeah.
But she's not really going, right? That often?
She's going, it's a requirement of our program that she go once a month. And she was doing it by telephone because rides were a big problem. Most recently, we've got it worked out that she can go attend one of the meetings here at New River Health. Of course, I'm home right now, but attend a meeting at New River Health and get an individual counseling at the same time, because the meetings aren't the official go into our medical record type meetings, just a meeting for accounting purposes. So she'll get counseling when she gets it at a Wednesday at 4 p.m. And that was a good thing to work out because it addressed some transportation problems.
One thing
She is
that
willing to walk 2 miles to attend these meetings just to be in the program. And then a 2-mile walk home. And she's done that before.
one thing that I see with patients who have PTSD problems is that they often resent the perpetrator of their trauma. And so sometimes that can come out in the relationship with the treatment folks, you know, that she resents authority so much that she defeats the treatment as a way of winning, and then not doing well as a way of defeating the treatment. Do you follow me?
Jeremy, you're right on point. She says, quote, "I don't trust anybody."
So sometimes just pointing that out to her and saying, you know, you had this terrible experience when you were young, you were mistreated, and I wonder if you kind of resent people in authority because of what happened. And I wonder if that's being played out in what's happening with us providing treatment for you. You know, it's hard for me to put together why you wouldn't want to try rehab so you could be better for your grandchildren instead of being kind of in the midst of addiction and trying to support your grandchildren. And you used to work and be productive, and it seems like your quality of life has gone way downhill.
Logically, that all makes sense.
Thank you so much, Dr. Hirschler. And does anybody else have any comments or questions regarding this case before you go into the didactic?
So real quick, I want to point out like how awesome it is that she's walking 2 miles just to get to treatment. Like I know people that wouldn't walk a quarter of a mile. And so like I think that connection that she has either with the treatment team or the group or whoever, or all of the above, is really, really something to kind of capitalize on. And I think part of of the incorporation of the individual therapy piece to help address some of the trauma and connections that she has struggled with in the past can help, her accomplish some of her goals, and maybe even overcome some of this learned helplessness that Derek was talking about. But I think just validating that struggle, like Dr. Hirschler was saying, but also hey, listen, you showed up, you walked 2 miles to get to this, that's awesome. And so just also as providers yourselves, that it's, the pat on the back that she's coming and she's walking that far, congratulations, that's awesome. You guys must have worked really, really hard to establish that connection and that trust that she has in y'all.
And let me correct it, it's a 2-hour walk. And a 2-hour walk back. So I made a mistake there. It's to Oak Hill.
That's even longer than 2 miles then. So
It's
that's
even-
even better.
It's even better.
I don't
Yes.
walk 2 hours in a day, period.
Right?
Same.
Well,
Jennifer?
2 years in a year, I think, maybe.
She gets along well with Thomas, our peer support person. That's a big support for her. Of course, Thomas is also trying to enable her as best he can, bringing the insure and this and that. And I'll do that. I'll do that too. I'll bring in food and give it to her, quite honestly.
Is there any way you could do a little bit of a contingency management type thing where, she's test negative for something and you could give her, not to take away the insurers or anything that you're already providing, but I don't know if there'd be
something extra. We've tried,
that idea.
yeah, since she's been in the program, we've tried contingency management at least once with that whole group because, we have people who haven't really moved on in 1 to 4 years, but it's something we haven't seen much success, but it's something that I continue to want to return to. So that's a good suggestion too. These are all really helpful suggestions to me. I thank you all.
And Laura, I saw you on mute for a moment. Did you want to chime in before you move on?
Yeah, I don't have any words of wisdom really or anything, just to share, we have some cases that are similar to this too. And sometimes you just have to know that at least if they're showing up, they're still alive. It's tough. I know we've had some that are just really, really challenging. And we've tried contingency management. We've tried offering more support. We've tried arranging inpatient. We've tried all the things. And, sometimes it's just, well, at least if they're here, we know they're still alive.
Thank you.
My MO with her basically is kindness. I just feel like this person has not experienced much kindness in her life and doesn't experience it now. The situation with the tooth extractions was particularly horrifying to me. She did not get good care and did not get good follow-up care. And so anyway.
Thank you.
Appreciate everybody's suggestions a lot.
Absolutely. Thank you, everyone. And thank you for the case. We really do appreciate it. All right, we're ready for Dr. Husted's presentation. Did you want me to share my screen for your slides, or do you want me to give you that power?
I've got mine.
I trust you enough.
Thank
Maybe.
you. I appreciate it. Glad someone does. All right. Hello, everybody. Good to see you all. We got, is it coming through okay?
Yes.
Okay. Perfect. So I had an interesting weekend. Oh, it's probably presenter view. Let me change it. Let's see. Is it coming through okay now? Good.
Now it's good. Thank you.
Okay, you're welcome. So I had an interesting weekend. We decided to go to a Pirate game on Saturday. It hasn't rained out the entire year. And then, of course, the one game I go to, we have this torrential thunder shower. So they had us go back yesterday. So we went last night, and then it was extra innings. So it's been a long day, but nice to see you all. I'm hopeful this will be a good presentation for you. So I set an alarm. We got about 27-ish minutes. So what we're going to talk about today is long-acting buprenorphine MOUD options. So the things that we have, that's me. I don't have any disclosures. I don't got any ties to pharmaceuticals, although I have met with some of the people at times to try to learn a little bit more about the treatments offered. So they're all FDA approved for the treatment of OUD. I work mainly in outpatient now. I do the IOP program here. I also do some other stuff with WVCTSI, and I got lots of people I work with. So the objectives of this are we're going to talk about briefly medication options for opioid use disorder. We know them, but we'll discuss them. We'll talk about the long-acting formulations, especially the new one, Brixadi. So we'll see how much time we have to go into that. And then I'm going to, this is for my son, add some goofy kid humor for my son's big joke book. So this is the big book of silly jokes for kids, 800 jokes plus. So he selected these. I don't agree with that all of them are funny, but they're goofy and silly, and I hope it helps a little bit. So we'll go into it. So of course, MAT or MOUD or whatever we're calling it these days is the gold standard of treatment. We all know it. If it's efficacious, it's really efficacious, and it's really the only ethical medical treatment that's available now. Everybody recommends doing it. That includes all these people, including ASAM, SAMHSA, NIH, AAAP. We have 3 medicines, of course, that we use. So, of course, methadone is our old faithful, which is still very difficult to get. You have to be in an OTP, although actually there's a potential legislation that could change availability of methadone where it could be prescribed through pharmacies. So stay tuned, but things could change in the near future where it could include, potentially a methadone arm, which would be kind of neat. Maybe for tough cases that we've discussed where just buprenorphine doesn't do the trick. We, of course, have naltrexone, with Vivitrol, and then buprenorphine. And what are we trying to do? Going back to the case that we just spoke about, but we're trying to decrease morbidity and mortality. So even when people are sometimes struggling, they're still alive, and that's something, and that's not an insignificant thing. So just keeping people alive and alleviating some of the suffering. And when people are alive, we ideally are trying to increase their quality of life. So give them a life more worth living, give them back some of the things that substance use has taken from them. Okay, so this is the first of the jokes. When is music like vegetables? When you dance to the beat. So there you go. Yeah, that's kid humor there. So when you dance to the beat. So when it comes to long acting, so what if we could use long acting? So what are the benefits potentially? So of course, if you're more, say from the criminal justice side, you don't like to see medicine get diverted. I don't like to see medicine get diverted, but when you use injectables, there's no diversion involved, right? So that's one thing. There's no risk of IV use if it's already there. So there's potential for people to misuse sublingual oral medicines, but not if you're using an injectable. Not having to take something daily. That's a benefit from that many people are actually, many people who have decided to switch over, it's because they get tired of taking medicines every day. Smoother course of treatment / withdrawal, potentially. That's one aspect of it. So say you miss a shot or you decide to come off of it, is it easier to do so with the injectables? Possibly. The idea that might be more accepted, different things, less stigma involved. Right or wrong, some of the facilities in the state require people to be on injectable if they're to take buprenorphine. They won't let people take sublingual. I don't really agree with that, but it is the way it is right now. Is it the ultimate opioid addiction cure? Probably not, but in theory, it might be nice, right? That you just get your shot and that's it. What are the downsides of it? There are some. So it is expensive. So if we switched everybody over to Sublocade, who's on Suboxone right now in the state, we might bankrupt state Medicaid. So we can't do that. As much as there's lots of people that may be better served with it. The reality is there's no way we can just, financially afford to put everybody on it. Not that everybody should be, but we can't just switch everybody over, as much as the pharmaceuticals would love that. And I've told it to their faces. If you keep pushing too much, we're gonna bankrupt the state, and no one's gonna pay for Sublocade anymore. So please lower the price ASAP. Side effects, injections. You get side effects from taking injections. Side effects that you may not get from taking films. Maybe You miss out on some of the GI effects, perhaps some of the dental problems you might deal with, taking a film every day or a tablet sublingual, but you're going to introduce other potential side effects. What about adherence? In a way, it's easier to be adherent to a shot once a month, but you still have to show up to get your shot once a month, of course. Difficulty obtaining and administering, which we'll talk about as one of the issues that was a problem with Sublocade. And, hopefully it's not going to be as much of a problem with the new one, Brixadi, since we've kind of run through Sublocade and dealing with the stressors with REMS, for instance, but we'll see. A concern for me is, again, this heavy advertising by Big Pharma. The last couple large like AAAP, ASAM events I've been to, the number one sponsor was Indivior for Sublocade. And then I think the number two sponsor was Braeburn, which does Brixadi, or is about to. And number three was Alkermes, which is Vivitrol. So there you go. Those are kind of the big sponsors at some of the substance use conferences. What about the false sense of security and stability? Again, sometimes people almost get lulled into sleep of their recovery, that you get the shot and you're cured of your addiction, or there's no potential for overdose if, say, you drank alcohol, or perhaps even if you use a lot of fentanyl. And the truth is, bad things can still happen to you, so you got to be careful. So what are the options we have at this point? So historically, we had probufene, which we'll very briefly talk about. This was approved in September 2015, and it was voluntarily taken off the market, basically because not enough people were using it in 2020. So we don't actually use this anymore, but who knows, maybe it'll make a comeback at some point. Stranger things have happened over the course of medical pharmaceutical history. Sublocade. So Sublocade is the big one that we've had now for 6 years almost, which is kind of hard to believe. So November of 2017, we've had Sublocade since then. And then, of course, Brixadi, which was just approved literally, 3 months ago, just about 3 months ago, which is pretty exciting, but not really commercially available quite yet. So you're not going to find anyone that's being given Brixadi through like a pharmacy or anything. You may come across folks that are getting it in different formulations through research studies, but it's not commercially available yet, but it will be very soon. So very briefly in the probufene, which we don't have anymore, but these were rods that you implanted in people's arms. They lasted for 6 months. It was ideally used for people that were on low doses of Suboxone or other forms of sublingual. It's of course approved for people 16 and older, which 16 and older is the approval for any form of buprenorphine. You had to put 4 rods in people's arms under local anesthesia. You had to have special training to do said procedure. Dr. Zhang is the only one that I know around, at least at WVU, that was able to do it. And I don't think he ever actually had the opportunity to even implant these. And the other issue was, so they lasted 6 months in each arm, but you could only put them in each arm one time. So you could only be on this treatment for 1 year. So you can see some of the downsides and why it was taken off the market. So just some pictures, put in people's arms, a little bit like a Nexplanon implant in a way. So you had to put these little rods in people's arms, you put them there, and then when the time came after 6 months of being in there, you actually had to cut in their arm and pull them out. So not available anymore, but who knows, maybe it'll make a comeback in some other form, perhaps, one rod that can be put multiple times in the same arm. Who knows? We'll see. So here's another one from my son. Why are playing cards like wolves? Well, of course, because they come in packs. So there you go. So Sublocade. Sublocade, we know it. I don't know if we love it, but it's something. It's been around for a while now. So it's, of course, an injectable subcutaneous buprenorphine solution. So you have to refrigerate it. You can only leave it out for up to 7 days, lest it go bad. It's indicated for people with moderate to severe opioid use disorder, like all forms of buprenorphine. And a big thing that you run into with Sublocade is that you have to be on, or it's recommended, you have to be on oral buprenorphine for 7 days to start. Now, I will say I've actually talked to the folks from Indivior. I have a pretty open relationship with the one rep who kind of oversees the whole region. And, this is something I pointed out to them as a big limitation with Sublocade. And they've actually approached the FDA about trying to be able to start people more quickly on it. So not having to be maintained for a week on Sublocade. And I will say at times, at times you'll see it given shorter than an entire week of being given. I've seen research protocol where it's given after, 1 day of sublingual films, or even a couple test doses. But for right now, as an outpatient, you're supposed to have somebody maintained for 1 week on sublingual prior to moving them over to Sublocade. So there's only 2 shots that are 300 and 100 milligram, and you can only place them in the abdomen, which becomes an issue at times. You can stay on it for basically ever. And it is being very heavily marketed. So lots of entities, the legal system in particular tends to be one that Indivior is really talking to. So one thing is, say, in maintenance during incarceration. So you don't want people getting films or tabs, in Medline, potential for diversion, you just give them a shot. And of course, for planned prison releases and question mark drug courts. So I know it's being marketed. I haven't seen it so much where they've sort of demanded people be on the shot in drug courts, but it's a concern. Okay, a little bit more on indications. So again, severe opioid use disorder, you have to be on it for 7 days. Sublingual films. It should only be used as a part of a complete treatment program that includes counseling and psychosocial report, just like any form of BUP. And the equivalence varies, but anywhere from 8 to 24 milligrams of BUP daily. This is kind of neat. After steady state has been achieved, so that's 4 to 6 months, patients discontinuing Sublocade may have detectable plasma levels of buprenorphine for 12 months or longer. That's a long time to still have in your system. So getting 6 months of shots and then potentially still testing positive for buprenorphine months and months, a year later, is a thing. We've actually had this issue with some people in the clinic where they've discontinued taking Sublocade, and then maybe they got incarcerated, or they got no drug program. They told them, "Hey, I'm off of Suboxone, I'm off Sublocade," and they're still testing positive for buprenorphine months later. So we've had to send letters and tell people, yes, it's entirely possible for folks to test positive for these low levels of buprenorphine. So just kind of keep that on your radar, that if someone's been on it for a while, it may linger for quite a while. So how do you administer Sublocade? It's a bit tricky, and there's specialized training for it. So it goes in the abdomen only. You don't put it intravenously, you don't put it intramuscularly, and you don't put it intradermally. That's where you get some real issues with skin breakdown. Only healthcare providers should prepare and administer it. The patient never has access to the medicine itself. It's meant to be given at least with 26 days between doses. So we typically give every 28 days in clinic to sort of keep them on track with other treatment within the code program. It doesn't really matter if someone's in weekly or monthly. We're still trying to give them the shot every 28 days and still have them obviously do their weekly group or biweekly group or whatever. So initiating treatment with Sublocade is the first buprenorphine product has not been studied. So again, you have to start with an induction and dose adjustment with the transmucosal, again, 7 days at least. But they are looking to change this, the pharmaceutical. All right, so 4 spots you can put Sublocade in. Basically, draw a line between your belly button, so make like a plus sign, and you take each quarter of it, of your abdomen, and that's where you can put these shots. As you can imagine, over time, you may run out of real estate with that. So you're supposed to pinch up the skin. So you're trying to get, again, to a subcutaneous area. And you have to go in at sort of a weird 45-degree angle. So you don't go straight down, you don't go straight across. Otherwise, you're going to put it too superficially. So you don't want to go too deep. You don't want to go into the skin, less problems happen. So it's a bit of a fine art. The volume is 0.5 mLs or 1.5 mLs, which doesn't sound like a lot, but if you're familiar with shots, that's actually a decent amount, especially this bigger one. But it's a decent little bolus of medicine that you're putting in the subcutaneous area, much more than, say, someone who's getting they're giving themselves a injection of insulin. Okay, so the dosing is very very straightforward in many ways. So it's 300 milligram for the first 2 months, and then the maintenance dose is supposed to be 100 milligrams monthly after this. From the third dose on, it's 100. You can increase the maintenance dose to 300. So for these are people that tolerate the 100 milligram dose, of course, but do not demonstrate a satisfactory clinical response. So that can be a little bit vague, and for Medicaid, it can be a little bit vague, but if someone's not doing well with lowering from 300 to 100, then you could, raise them back to a 300 maintenance dose. So what they say is evidenced by self-reported illicit opioid use. So that's, again, a little bit vague in a way that, it's pretty subjective at least, or urine drug screens positive for illicit opioid use. So, I don't know the percentage of people that have remained on 300 versus 100 milligrams, but we've had a decent number of folks that just didn't do great lowering to 100. And if you ask me why there isn't a 200, well, I asked that to the drug reps and they said they didn't see anything with it. So we only have these 2 doses. But so 300 milligrams, 300 milligrams, second dose, 100 for the third dose. This is actually, this graph, this is from the package insert, but this is for people established on long-term treatment with transmucosal buprenorphine. So these are people that have been in treatment for a while. They're on Suboxone and they're doing fine. What's the equivalent for them? What they recommend is for these higher doses, you start with 300 milligram shot, but actually somebody on a slightly lower, I guess you could say average dose, theoretically, they could actually get a 300 one time and then go down to 100. But we often still will use 300, 100. All right. So adverse reactions, we mentioned them a little bit, but you will get injection site reactions, but you also get things like constipation, headache, nausea, vomiting, sometimes hepatic enzyme increases and fatigue. So injection site reactions are certainly a problem: pain, erythema, and pruritus. But the other things that we say is these, and we've certainly seen these here at our clinic, are these injection site reactions where people get abscesses there, ulceration, necrosis. It's probably, sometimes it seems like it has to do with just improper administration. It's being given too superficially, basically put directly in the skin, and that's not great. Other times it's kind of a question mark if it's related to just the medicine itself. I will say it's extremely common for people to still have a little knot, a little lump there, maybe the size of, say like an almond maybe, that can last for quite a while. We're talking months. I've had people that, 6 months, 7 months later, they still have their lump from the first time. So kind of when you're going back around the abdomen, again, you only have 4 spots. You're making your way around the circle and you're trying to avoid, previous lumps essentially. Of course, the likelihood of serious injection site reactions may be increased with inadvertent administration. So there you go. A little bit in the Sublocade, so typically used in patients on moderate to higher buprenorphine doses, although we've seen that the dose doesn't always correlate with how much people need. And, people even on lower doses of Suboxone, say, 6 milligrams, 8 milligrams, still can tolerate Sublocade pretty well. Usually Medicaid won't pay for it unless someone's on at least 8, though, I will say. So have to be on 8 milligrams consistently, at least a week of it, to qualify for Sublocade, for what's worth. You don't start it immediately. You have to be on the films for 7 days. It's only given monthly. There's only 2 strengths available. Okay. And of course, it's into the abdomen only, and you will see these serious injection site reactions from time to time. You do need a REMS program set up to be able to give this, and the REMS program is specifically through the pharmacy that obtains it from the wholesaler. But there has to be a REMS program in place. This is always step number 1 when you're trying to get Sublocade. So without the REMS program, it's going to be really hard to get people their medicine. And the use as a discontinuation treatment has not been thoroughly studied, but in theory, it could be a good option given these extended levels after discontinuing. And we've certainly seen some people that have stopped Sublocade and they've been able to discontinue taking buprenorphine and haven't relapsed. So it definitely has potential. So keep it in mind, perhaps if someone's never done well coming off films, they really want to try coming off of, put them on the, a few months worth of shot and see how they do. It's got potential. The cost of Sublocade, this is around $1,750. The cost is actually the same between the 300 and 100, which always confuses me why we have problems with Medicaid, because it doesn't, like, the cost doesn't matter between two shots. I know our pharmacy, to get it wholesale retail, it's like $2,000 here, so it's a decent chunk of change each shot. And again, if you had 1,000 people on the shot every month, you could do some damage to Medicaid. All right, so here's a good one. I do like this joke. So what do you call a pig who knows karate? Pork chop. I like that, pork chop. That's a good one. Silly kid jokes. Wonderful. All right. Lastly, Brixadi / Buvidol / CAM 2038, whatever you want to call it, but we're calling it Brixadi now. So it's similar to Sublocade in many ways. So it's a injectable subcutaneous solution. So it was approved and used in the European Union since November 2018 as Buvidol. And this was actually their first approved shot. So it's been around for now 5-ish years in other countries. We've had Sublocade, they've had Brixadi, or Buvidol as they called it. So it's intended for children 16 and older, and adults, okay? So it was originally tentatively approved in 2018, but was not eligible due to actually Sublocade kind of blocked it. And then it was 2020. It kind of got pushed back a little bit. And then finally, it was supposed to actually be approved in 2020, and it was delayed due to partially COVID, but also some manufacturer issues. So not with Braeburn, who makes it in Sweden originally, but it's a complicated process. But some of it's made in Sweden, shipped over, and then it's like fully put together in the US, and it's just, there's issues. But anyways, it was finally approved just a couple months back in May, so May 23rd. And the idea is it should be available commercially as soon as next month. So hopefully this is a good time for us to talk about this stuff, but very soon. So how do we use it? What are its uses? So of course, moderate to severe opioid use disorder. One of the nice things is you don't have to refrigerate the medicine. So you can have it pretty much anywhere stored, pull it out and give them the shot. It forms this liquid crystal gel under the skin, which is pretty interesting. So there's weekly, which are Q7 days, and monthly for them is actually every 28 days. So that's what they want, is 28 days. It's a little less vague than Sublocade, where Sublocade says, a month. For them, Brixadi is every 28 days. So there's different doses available, but you have 8 milligrams, 16, 24, 32 of the weekly. Monthly is 64, 96, and 128. In Europe, they actually have a 160, which the US does not have, but who knows, that could be an option down the line. It's placed subcutaneously, again, like Sublocade, but you can put it in different areas. So it doesn't just have to be in the abdomen. You can put it in the thighs, you can put it in people's butts. You can put it in the shoulders, although from what we've been told in the research study that we use, shoulders actually have less absorption. So it's better to go in one of the other areas just to kind of get the most bang for your buck. So these are all the areas that you can place. It's a lot more simple. I've administered probably at least 50 to 100 of these shots, again, through research purposes, is CAM 2038. But all you have to do is pinch up the skin, put the plunger in, squirt it in, pull it out. That's it. You don't really need anything in the way of special training. You don't draw back or anything to see blood. It's really straightforward and easy. And it's actually less volume than Sublocade. So 0.16 mLs is the smallest of the solutions. 0.64 is the highest of weekly. And actually in the monthly, 0.18 and 0.36. So all these doses except this one are less than Sublocade, which is pretty wild. So total solution volume, again, 0.6 to 0.64 mLs. and actually it's more concentrated the monthly, so 0.18 to 0.36. So a pretty small amount of actual medicine, this volume of medicine that's going under the skin. So a little bit into those comparability and side effects. So the idea is that new patients are started on weekly shots and then ideally transition to monthly, whereas established buprenorphine patients can immediately proceed to monthly. So if someone is new to bup entirely, you should start with the weekly. If someone's been stable on sublingual bup for a while, they can actually immediately jump to monthly. So these are for established people, but the idea being less than 6, this is equivalent to 8 of the weekly, but really where you're seeing it is more like the 8 to 10, 12 to 16, 18 to 24. So these doses of 64, 96, 128, and you can tell there's a lot of differences in terms of the dosings from Sublocade, which, you know, the max dose is 300, but at 128 of Brixadi is equivalent to the same as a Sublocade 300 essentially, okay? The adverse reactions commonly associated with Brixadi. So these are injection site pain. You can have headache, constipation, nausea, injection site redness, basically itching, insomnia, and urinary tract infection. So that's on the packaging insert, which is available. This is where it gets a little bit tricky. So for new bup patients, again, people just starting out. So this is for people not currently receiving buprenorphine. So what's recommended is 24 milligrams for the first week, and this is how you do it. So they still recommend that you use at least 1 test dose of transmucosal Suboxone, so 4 milligrams of either Suboxone or Subutex or whatever. But you should always still test the waters with some form of sublingual bup before you transmucosal bup before you make the leap of giving someone a shot. Okay. So the first dose tends to be 16, and this is actually very similar to what we do in the research protocol. So this is what we've been doing successfully for lots of patients. I think we have about 30-ish people that are, oh, my timer's going off here. So we're getting close to the end, sorry. So we have about 30 people that we've done this for successfully. Okay, so within a few days of giving that first dose of 16, they actually recommend this 8 milligram booster dose. So the lowest dose typically is not used as a maintenance, but you give a booster dose to equal 24 milligrams total weekly. So for the first week. So what you try to do is get them stable on a dose of, basically 24 or a maximum of 32 milligrams. So you sort out what works, and then you transition them from weekly to monthly, or from monthly to weekly based on clinical judgment. So say someone is stable on that lower dose of 16, the extra 8 was a little too much and they just want to stick with 16. 64 might be a good amount, or you get someone at the 24, they're stable, go up to 96, which again is equivalent to basically 2 films a day. Whereas something like the 32 milligrams or 128, we're talking more around the equivalent to 3 films a day or 24 milligrams. Okay, so slightly more complicated than Sublocade, but I think we'll all get the hang of it pretty quickly. All right, a little bit in the discontinuation of Brixadi. So it's actually, again, being actively studied as a discontinuation agent versus sublingual bup and actually XR naltrexone. So that's what we're doing in the one study here. There's no recommended maximum duration of treatment. And, people can potentially remain on it indefinitely, just like Sublocade. Of course, we always, people should, consider if they want to come off of it or not. Clinical judgment, clinical status, it's their decision to continue or discontinue. When you discontinue it, again, considering that it is an extended release medicine, and it can take a while before they have any withdrawal symptoms, if they have any at all. So similar to Sublocade, but perhaps not quite as long. But when you've been on weekly Brixadi, so 4 weeks of Brixadi, so that's steady state, you'll actually have these detectable plasma levels for a while. So if you're 4 months of monthly Brixadi, I can actually stay in your system for about the same amount of time. So 4 months continuing after you discontinue. And with weekly, it's about a month worth. So you stay on it for a month of weekly, it'll stay in your system for a month after you stop. If you stay on it for 4 months of monthly, it'll stay in your system for 4 months afterwards. So these are, keep in mind, these are plasma levels though, and not really correlated with urine drug screens. Although I'll say in the study, I think one guy we had on the longest, who then discontinued, he was on it for like 8 months, and it took 3 or 4 months for it to get out of his system, because we actually transitioned him to Vivitrol, which he wanted afterwards. So we kind of had him on Brixadi for a while, CAM 2038, the research designation. Had him on it for a while. He was stable, took him off of it, stayed in the system for 3 or 4 months, and then got him over to Vivitrol, which is kind of cool. All right, so keys in the Brixadi, and we're almost done. So it was approved just recently, and it should be available very soon. It can be used in people on various buprenorphine doses, given what's available. You just need 1 test dose of SL-Bup to initiate, not 1 week of sublingual. We have these weekly and monthly forms available, so it gives you some flexibility. And then the subcutaneous shots can be used in different sites, not just the abdomen. And it does or will require a REMS program, which you can just Google Brixadi REMS and see what you need, but you have to have a designated healthcare provider, which is typically through the pharmacy, to distribute this stuff. You don't actually need to be REMS certified as an individual prescriber, which is interesting. So to prescribe it, you don't have to have a REMS program, but you have to know who has one to kind of send it to appropriately. Okay. Cost of Brixadi, lastly, is kind of a question mark. So the rumor is, what I hear is it's less than Sublocade, and my hope is that the 2 of them being out there at the same time will drive down the cost of both injectables. Again, we don't want to bankrupt the healthcare system, but we want people to get good treatment. Okay. So last joke, and we'll end it. How do turtles talk to each other? It's by using shell phones, of course. So very nice. Okay. Conclusions, of course, MAT is a gold standard treatment. It's the most effective treatment. It's really the only ethical thing we can do as physicians. We have these long-acting forms, which offer a lot of promise. Sublocade is what we have, the only thing we've had for a while now, but Brixadi is approved and it's almost here, which is pretty cool. The long-acting forms are not a cure, but they certainly offer a good choice for the right patients and situations, and try to continue to be good advocates for effective OUD treatments. So does anybody have any questions? And there's some new updated photos of my kids. I love how my daughter's trying to hold the cat, and the cat does not look happy, but the cat is trying his best to be a good sport. So
Thank
All
you
right.
so much. Love the jokes. Love
Yes.
the pictures. Those are kid jokes / might be dad jokes. It's bordering, you know.
I felt the same way, but technically I don't have like a book of dad jokes. I'll try to get.
You better get on that. Does
Yeah.
anybody have any questions or comments?
I have a question, Jeremy. Is there any evidence that Brixadi will work well for chronic pain?
I mean, I would assume it would, just like Sublocade has the potential to help with chronic pain. You know, I don't see any reason it wouldn't, but they certainly haven't chased down the indication for it. So, I mean,
The thing that comes to my mind is when you use sublingual, you want to divide it up into several times a day.
yeah,
Then when you have these long-acting formulations, it's going to be a steady state kind of thing. I just wonder if that's going to offer different analgesic benefits.
when you think about it, when you divide it up more times a day in a way that helps you to achieve a more even steady state, a way because you're not having those peaks and troughs. So in a way, the shot is basically like frequent dosing. So I don't look at it as like someone taking a huge dose of Suboxone and then it wanes it off. It is basically like just continued frequent dosing. So it looks
I
like
have a
Mark's
question,
stuck in weather too. Yes,
Yeah.
David. So.
Yeah, so I finally took the plunge and started a patient on Sublocade, got it
Did you?
approved because our pharmacy is now doing it. But
Nice.
4 days later, she was withdrawing
Really?
on the 300 milligrams. And I'm like, well, psychological, this, that, talked to her. Her symptoms were withdrawal. Wrote her, gave her some more Suboxone, and her withdrawal went away. And so I don't know if you have any experience with that. Was the injection, it was sub-Q, it was done at the hospital.
Yeah.
You know, pharmacy kind of guided him through it. You know, she's only on 24. I mean, only that's, you know, kind of, so she's on 24, but she is somebody who had misused her strips before, which is concerning, but maybe she kept feeling like she was withdrawing even on the 24.
Yeah.
So I don't know if that's, any hints on that.
I think sometimes it's not administered great. I know we've had people that they basically pulled out the plunger too quickly and lost some medicine. I think there are some people that generally just don't respond to it for whatever reason. The depot doesn't enter their bloodstream. Maybe they're metabolizing it quicker for whatever reason.
Right.
We've had people in the research study, whether it's Brixadi or in normal clinic on Sublocade, that have had to remain on some amount of films.
Okay.
I actually insanely researched Sublocade whenever anyway, you don't need to know all the details about why I went to that rabbit hole, but I did. And part of what I read was that when you first initiate people, sometimes you do have to add a little of the sublingual until that level gets steady in their system.
And like I said, it can take 4 months or 4 to 6 months to achieve before steady.
So then my question was, she'd been on it before and did fine, but she doesn't remember what dose she had been on or any, before. But she's not getting overdose. She's got the 300 milligrams in her system and getting, 16 milligrams of, Suboxone as well. Do we abandon or try a second shot? Any clinical hints on that?
I think it wouldn't be a bad idea to try it again, because you got to think with the shots again, one shot is going to last more than a month. So there is sort of this effect where they, the dose plasma level, it's going to stack on itself. So I think it's worthwhile trying again. If she's willing to take it and didn't have any major side effects with it, maybe it's just suboptimal response. I would definitely say with her though, is if she's needing all the supplemental films, dropping down to 100 at the third dose would probably not be the greatest idea.
Right.
Now, the nice thing with Brixadi is you can do these weekly shots and really kind of test the waters first, because with Sublocade, once you got 300 in, you're kind of stuck for a month. If someone has a really bad reaction to it, you're not sure what's going to happen really.
Okay. Thanks.
Yep. Sorry, we've gone over a little bit, but hopefully this is helpful for everybody, since this might be a new treatment of care.
No, appreciate it. No worries at all. Fred, I saw you on mute. Did you have questions or comments to add, or did they get answered?
Well, I was going to say that I know for those who've been on Sublocade down here at the Healing House and areas, they've all had subs with them. Every one of them, even started on the 300s. And I think we've only had one get down to the 100 and stay, where the other 3 or 4 went back to 300s. So I haven't seen or know of too many people who did well on the 100.
Yeah.
That's all.
That has been something, again, we've noticed in clinic. I'll say with the Brixadi is it's not so much like, oh, have them on 128 and then go to 64 and kind of keep them there. It's more like, okay, if they do well on 96 or 128 or whatever, you just keep them at that dose. We've had people that have taken that dose for a year and a half and they're doing excellent. And they're not taking any extra films. Like I think we gave them some extra films when they first started it, but most of them haven't really required additional films. You get every 28 days, so that's what.
Thank you.
You're welcome. Anything else? I would say if y'all, again, Google REMS if you're interested in this. Whatever pharmacy you already have with Sublocade, I would say start with them. That they would probably be interested in getting Brixadi, because it's probably going to cost them less. Medicaid, I imagine Medicaid will hopefully be pretty receptive to this as a way to drop costs. I know like Peak Health, for instance, I'm part of their stuff, and I'm going to make sure it's approved the minute it's out. You'll be able to get it in Peak Health although it's usually counted as a medical benefit, like Sublocade's a medical benefit, so it can't really be run through as a pharmaceutical benefit, which makes things a little complicated. But the hope is to not wait like 2 or 3 years like we did with Sublocade, that Brixadi will be approved pretty quickly once it comes out, as long as you have the REMS program in place. So
Excellent. Thank you so much, Dr. Houston. Does anybody else have any questions? You can always email us and we could do a part 2 of this or further in-depth dive. Just let us know, email us so we can give you guys what you need and want currently. All right, with that said, I only have one announcement. Next time we'll be meeting will be August 28th, and Dr. Hirschler will be discussing and advancing quality of life in patients with SUD. So stay tuned for that email, and we hope you guys have a great rest of your week. Thank you.
Go Buffalo Plaid, by the way.
Buffalo Plaid.
Yep. See y'all. Thanks.